My personal preference is not only based on the fact that I do enjoy the technically more challenging cases, but I certainly do see a difference in patient satisfaction between the two procedures, where the using your own body tissue has been shown to have significantly higher rates of satisfaction when compared to implant-based reconstruction. In fact, I did a study when I was at Duke University with over 7,600 women, and we asked women of the whole spectrum of breast cancer procedures, women who had lumpectomies, women who had mastectomies alone, women with all different types of reconstruction. We asked them about their satisfaction with their breast and their quality of life. And surprisingly, women who had mastectomies with using your own body tissue or using your thigh or gluteal tissue reported even higher satisfaction than women who had lumpectomies. So clearly, the operation left women very satisfied with their size and their symmetry and the softness and the natural feeling of their breast. And they also had the longest long-term satisfaction as well. These were women who didn't have to get implants exchanged several years down the road. There was no issues, very few issues with infection. So generally speaking, women who use their own body tissue are significantly more satisfied with their outcome. And I do talk to women about that. With that being said, it's very important to note that these are very complex operations, which often take a lot of investment on the patient's part as well as the surgeon's part. The operations are long, the recovery is longer. So if women understand that up front and are okay with that, then I think it's an excellent option for breast reconstruction. Well, it's a little bit like a tummy tuck scar, except it may be slightly more extensive. It's in the lower abdomen, sort of along the pubic line, and then extends from hip to hip. So it's a pretty significant scar, but we can often do a nice job of trying to hide it in your underwear or bikinis or bathing suits. But it does give you, it does allow us to remove a lot of unwanted lower abdominal tissue, and that's where most women tend to carry a lot of their weight. A lot of that depends on whether or not this is an immediate-based reconstruction, where the reconstruction takes place at the time of the mastectomy, or if it's done at a later time. And the reason is when you have an immediate breast reconstruction, you're able to preserve most of the skin envelope, particularly if the patient is not going to have radiation. And so if you're preserving most of the chest wall skin envelope, oftentimes we're able to just take out the nipple and areolar complex, and the only thing you see from the breast reconstruction is the small skin paddle from either the lower abdomen or the thigh or the gluteus, wherever we take it from. So the scars are quite minimal. There are times, though, in the delayed reconstruction cases when the patient has had a mastectomy already, they've already had radiation, and that tissue is no longer stretchable. So we often have to replace all that chest wall skin with the skin from the area we're taking it from. So that their entire breast will essentially be the lower abdominal skin if we were to take it from the lower abdomen. I have to say I'm very evidence-based practicing physician. And I grew up in the area when silicone implants were back. So I was lucky in that was, in my armamentarium of different options that I could use for breast reconstruction patients. So my preference is to definitely use silicone over saline for implant-based reconstruction. And the reason being is that women do report significantly higher satisfaction with silicone reconstruction than they do with saline. And that was a paper that was published by Dr. Pusick and Dr. Amy Alderman. And it was an excellent paper using the breast Q to evaluate patient outcomes. So women report that they feel softer, they look more natural, and I would say I completely agree with that. Today's silicone implant is a much more cohesive gel than the one that they had back in the 70s and in the 80s. So theoretically, this silicone, even if the outer shell were to rupture, wouldn't spill into the surrounding tissues and wouldn't theoretically cause the sort of horrible local reaction that a lot of women had to ruptured silicone implants. Now, in terms of whether or not I prefer gummy bear over the silicone round gel implants, I think that the gummy bear implants are a beautiful option when we're doing the one and done or the direct to implant option. And I think for smaller breasted women who are not very wide chested and just kind of skinnier, smaller women, that the gummy bear implant can be a good option even after tissue expansion. I have to say though, a lot of the women that I reconstruct often need larger implants that range anywhere from the 600 to 800 cc volume. And when that's the case, usually the gummy bear implants don't do as nice of a job of providing the amount of sort of outward projection that we like to see in reconstruction. So typically in the larger volume of implants, I use the round silicone gel, non-gummy bear ones. What I tell women about the likelihood for replacing an implant down the road is that at 10 years, 50% of people will need to have their implants replaced. Now, I have seen patients that have had their implants in for 30 years without any complications, but that's quite unlikely. And after the 10-year mark, like everything, like our tires and like everything in life, there is a wear and tear associated with implants. So I tell women that at 10 years, 50% will require a replacement of their implant. I use a very old school way of creating a nipple, and that's called the skate flap. And the skate flap allows me to create the areola as well as the nipple at the same time using a skin graft. And I have to say that since I switched to using the skate flap, I have never had to take a patient back to recreate a nipple for them. The projection lasts for a significantly longer period of time, and the projection of the nipple, that is, lasts for a significantly longer period of time. They get an areola as well as a nipple, and they often have color in it. So I have been extremely satisfied with utilizing the skate flap. Now, that does require typically that you have to take skin from somewhere else. And often after a mastectomy, women will have a lot of excess skin in their kind of lateral aspect of their breast, and that's a great place to take it from. But it does require general anesthesia. And so it's not the simple, we could do this in my office type of a nipple reconstruction. With that being said, I have never had to take a patient back to the OR to recreate a nipple after a skate flap because it just has better blood supply and tends to provide much better projection. Well, I think women should be assured that there are all different types of reconstructive techniques out there for them, whether or not they're having a mastectomy versus a lumpectomy. First and foremost, the cancer is the most important thing that we need to treat, and then we can help them restore their body image and their quality of life based on all the different techniques that we can offer.